Right, hello and welcome to another episode of the Merseyside Health Podcast. I've got Jeff Morton here with me today. He's a specialist physiotherapist in lower limbs who works in the NHS. So welcome, Jeff. Do you mind giving us a bit of an introduction?
Yeah, absolutely. So I'm currently a lower limb specialist up in Broad Green in Tring and Royal and all over kind of south and north Liverpool within the NHS. I've been in advanced practice for coming up to 2 years now, and that's quite a kind of varied job plan. So for anyone who's local in the area and has had issues, you've probably been referred to the AMCAS service. So that's a service where we triage patients sent by GPs as to where the best care for them is, and whether they require any imaging or specialist referrals. Part of that will also involve working in the physiotherapy department for people who've been suffering with conditions for a particularly long time or particularly complex conditions that might need a little bit more kind of looking at and deciding where we go. And then part of the role is working in orthopaedic clinics alongside consultants, generally kind of post-ops and optimising people for surgeries, giving opinions on that. And then a few other bits, kind of like trying to promote research and innovation within the department.
Yeah, so super sort of busy and complicated role you've got yourself there pretty much, haven't you? Have you always been NHS or where have you come from before that?
Yeah, I've been mainly NHS, so I graduated in 2014 from Sheffield Hallam.
Oh, I didn't realise you were Sheffield Hallam.
Yeah.
It's getting a bit ridiculous now.
Is it?
I'm Sheffield Hallam and Abby O'Kell, who was on the podcast the other week, she's Sheffield Hallam as well.
Oh, you're
going to actually have to
very selective with it.
Yeah, you have to come on this podcast, you have to be trained in Sheffield Hallam.
Yeah, that's a good rule. It's all the best physios anyway.
Yeah, definitely. Oh, great.
So yeah, and then I started working as a rotational band 5 physiotherapist, which for anyone who's not familiar is kind of the grade that you start at as a qualified physio in the NHS. Did rotations around all areas, MSK, so joints, bones, muscles, neurology, respiratory. Really enjoyed the rehab aspect of it, not necessarily just kind of MSK or joints, muscles. I really enjoyed the neuro rehab side of things as well. I just so happened that when I decided that I liked this and I was more kind of inclined towards that than ward-based work, there was the Ward 5 kind of complex rehab ward in Broad Green that was still on the musculoskeletal rotor, but no one wanted to do it. Okay. So I jumped in, got the job and ended up spending a year on that inpatient ward, which is daily rehab for really complex patients, which I actually love. But then, yeah, moving forwards, because ultimately part of it is there's not huge amounts of job progression for neuro, unfortunately, in the NHS, and there is more funding towards the musculoskeletal side of things. So, I love rehab, and I can still do that with MSK, so I've just naturally progressed to this point.
And some people listening might think, well, what's he talking about? Surely all physio is rehab. Yeah. So, but it's not at all anymore, is it really? I suppose traditionally that's what physios were. We were in the gym or the gymnasium, as it would have been then, creating supple, flexible, fit, strong bodies. But how's the profession evolved? Because people might not necessarily realise.
Yeah, it's expanding, isn't it? So we've got completely different roles. So in the acute setting in a hospital, unfortunately, the rehab side might have been a little bit lost just purely due to the inpatient pressures. And actually, you can't treat people if you haven't got a bed on the ward to treat these people. And so a lot of inpatient physiotherapy might be more towards kind of optimising discharges and getting people settled for home so they can recover at home, which is ultimately the best place for people to recover once they're medically fit. But that's kind of an acute setting and might not get the time to actually engage in rehab as much just due to the volume of patients like you've got. From my understanding, I was last there during COVID.
Yeah, so one physio covering a ward of 25, I don't know, I've been in the NHS for a while.
Yeah, at least one ward, it's quite common, it's two.
Yeah, and maybe with an assistant to help you, trying to get around and do some meaningful therapy with all those people.
Yeah.
The maths doesn't quite work, does it?
Not quite, no. You can't spend time that you'd need to rehab someone most often. That's not a blanket. I know that if someone really, really needs it, then the time is made for that.
Yeah.
But on general, it's send people up for home and blended role with maybe occupational therapy and social work. And then on the other spectrum, you've got advanced practice, which is kind of taking away from rehab workforce a little bit. So we've got first contact practitioners, obviously, in GP practices, where people with MSK conditions or joint problems may be seen by someone who isn't a doctor. It could be physiotherapists, it could be other professions like pharmacists and nurse practitioners. And again, that's very much there's a huge demand in primary care, and the idea is ideally you can see someone who's presented with a problem that might be relatively acute or chronic, and deliver the information at that point rather than having to wait to go through to speak to someone in secondary care, which is more kind of hospital-based care. Because a lot of care for musculoskeletal patients is advice and education. If you can get that right at the very start, and again, that doesn't really allow, you can't rehab someone in a GP room. And so it's this kind of diversification of roles, I think, gives a physiotherapist options on where they want to go. And so it is no longer just rehab. Obviously, there is still the rehab services there, and that's what we see a lot of. It still is a bread and butter what we do. It's just not the only thing that we do.
And in that clinical assessment service, is it the case that you're expected to see someone on one occasion? Can you follow them up and bring them back in? Or is it a case of you're sending them on for investigation, you're referring them in to see a consultant or into a physio department where they might get follow-up there?
Yeah, so it's ideally, it's a one-stop kind of appointment, so you can guide the care. And so we do provide follow-ups if it's not kind of a surgical opinion that someone needs, if it's not investigations or referrals to other specialist services such as pain clinic or rheumatology. And actually the best thing is a course of rehab for someone, then we can follow them up in physiotherapy. But obviously if someone needs some investigations doing, then we'd follow them up within the MCAS service for that resolution of the case and then decide where they go.
Yeah, so if there's some diagnostic uncertainty, you think we're going to get an MRI for this person's knee, and then rather than send them to where you think they might need to go and wait for those results, hold on to them till you got the results, and then get them to the right place in the first instance.
Yeah, definitely. I think especially with the pressures on orthopaedics at the moment, we need to send them ready. Send patients with a diagnosis, and could you look at this specifically rather than maybe the surgeons having to spend extra appointments to then chase for investigations and things like that.
So if you've done your job well, they arrive at the surgeons with a plan. We think they need, never tell the surgeon what they need. You learn that the hard way, do you? But we think they need this. Do you agree? And then literally it's straight onto that intervention. Okay. And so for you as a therapist, then, I've done that job briefly, and it was very long, but your rehab skills are a skill set in themselves, aren't they? So how do you feel about, I suppose, not taking those patients through that rehab process, and not just you, what do you think that's doing to that group of physios? Is that a leading question? Probably. I don't know.
No, I think it maybe a little bit, but it's because we kind of know the answer a little bit, don't we? Yeah. I think from a personal perspective, I love rehab still, and it just so happens that my time is probably best spent doing other things in the current role that I'm in to try and help push different areas forwards and make the MCAS as efficient as it can be and stuff like that. Yeah. On a personal level, I still love rehab, and I love the kind of background leading into it. So it's it's quite sad, but it's a hobby for me to kind of keep up with what's going on in the rehab sphere and what's best practice look like. But for someone who doesn't maybe have that level of interest, because I realise that's uncommon, having a full FCP clinic of back-to-back patients in primary care, which can have, people in primary care have a lot of issues, and you're not just treating the one musculoskeletal problem, you're treating the person, and that, you know, at the end of the day can be quite tiring, can't it? So then having the energy to go on and keep up with what's happening in this world that I've got nothing to do with anymore is difficult. And so I think probably we are diluting the rehab knowledge a little bit for people who don't regularly do it.
Yeah, it's just one of those things, isn't it? If it's your full-time job to know about stuff and to be immersed in stuff, you know, and you're paid to do that, then you do it. But when you're asking it to be a hobby on top, great if you enjoy it, but it's just not going to be for everyone, is it? So, okay, well, this is why I've sort of found you, really, because I've followed you on Instagram for a while and found what you've been putting out there to be really interesting. Now, I would say now I'm a rehab physio. You know, in private practice, people are coming to me often with either a diagnosis already, or certainly with a strong idea of what they think it might be, whether that's from NCAS, GP, previous NHS Physio, but just not hitting whatever goal it is that they wanted to hit, and then my job is to pick them up from whatever stage they are and take them through. Or if I think that something's been missed, send them back to you guys in MCAS and try and get them in front of the person they need to be in front of. Oh, there's that nice bell there. We should probably say where we are, actually.
It's amazing room.
We're in the Vice Chancellor's room at Liverpool Hope University, the best room in the uni, so that's what that bell is in the background, that nice old bell on top of the room.
Yeah, you've treated me today.
Treated you. So, so in that more sort of rehab space, what do you think are the key skills that physios should have in rehab?
I mean, number one's got to be communication, hasn't it? I think that from personal experience, the people that I see who have got problems that are severely impacting them day to day, the common theme that I have is that when I ask them, okay, well, what have you been told is a problem? What's your understanding of what's going on? That it's quite difficult for them to recount that in any kind of accurate way, as according to my version of events. And so communication can probably halt a lot of problems at the start. And that's making sure that a person in front of you who's going through obviously enough problems to be sat in front of you feels like they've been listened to, understood. The impact of the problems that they're having on their life is taken seriously, and that there's a structured reason kind of plan in place as to what we're doing. And so you go into that active listening and the kind of research behind that shows that actually where it's been looked at previously, we're not that good. We'll interrupt people quite quickly.
No, we don't.
And then kind of the empathy, which is really what comes through, isn't it? We need to demonstrate. It's all well and good being empathetic, but we have to demonstrate our empathy and actually make sure the patient's aware that we do understand what they're going through. And I think that's probably what might happen, is that we are humans sat in front of other people, and we can't help but get caught up if someone's really going through trouble. Maybe not communicating that we understand the issues that they're having, because especially it's no kind of, it's not unknown that the NHS is going through quite a lot of difficulties at the moment. We've got, unfortunately, quite extensive waiting lists. Being on the ground and having a caseload is quite difficult in terms of time constraints. And so it's understandable why people might not have had that kind of conversation. But the ability to do that, and then I love the concept of beginning with the end in mind. Defining the end point of, well, we're going to give it this period of time because of X, Y, and Z, which is based off research, based off the patient's experiences and expectations. And if at X point we either have or haven't reached a goal, this is the plan. And I think that is by far the most important thing that we can do.
Yeah, and that question of time is key, isn't it? Because we often get people come in to see the practice, and they might say, not always, I'm not saying we always do this particularly well, but we'll often get comments like, oh, well, you are the first person that's explained it. And I'm always quite careful, having worked in the NHS for about 8 years, not to, for want of a better word, slag off the NHS, because I remember being in those 20-minute appointments and that patient maybe is 5 minutes late and there's another patient coming in, and it's very difficult to work under that time pressure. And I have to say, well, the difference is we've had 45 minutes. And so being able to kind of go over this message maybe 2 or 3 times and then get you to repeat it back and then correct if you, and get you to understand if you, that's a very different rehab environment. And also we've had 6 follow-ups. So that those time constraints are key, aren't they?
Definitely, and it's something that we've kind of broached before. Is just because it's the way it is now, and it's the way we've always done it, isn't necessarily the best way to do it. It's really difficult to try and plan that on an organisational level of how much time you allocate patients and what's that based off. Is that going to discriminate in some people? And so there's a whole lot that goes into making a change like that. I'm lucky because the people that I see are typically more of that kind of persistent pain, maybe don't quite understand exactly what's going on. I've made my template so that I do have 45 minutes, and that's the difference between seeing me and seeing someone else on the whole. I might have a little bit more experience in the orthopedic side of things and their reasoning and the imaging side. The knowledge that you and the explanation you'll get is probably what you'll get from someone else. It's just that I've got time to go over it.
check the understanding is there, and Okay, so communication, I would agree with you. It's got to be. If we don't have that, there's not really much point, is there? We had a brilliant course a couple of years ago with Alistair, who we were talking about off camera. Only nice things we were talking about you there, Alistair, if you're listening. And that was purely a course on communication, particularly with regards to people with learning disability and learning difficulties. So we can just go on forever and ever about communication. But after that, what would you say? What are the next kind of things that come into that rehab skill piece? In your opinion?
In my opinion.
Opinions will vary on this, I'm sure.
I mean, it comes down to, my brain works in a certain way. I need to have a framework of like, why am I doing what I'm doing? When that comes to, we'll kind of maybe leave advice because that, there's so much that tailored to the person, but on like a rehab perspective, so like what we consider like our bread and butter skills of exercise prescription, manual therapy, things like that. It comes down to me of having a framework for reasoning why I'm doing what I'm doing, and so I kind of, this is a false dichotomy, and it's not something that I've kind of publicised, but to me, a patient presenting with me after I've assessed them will probably either have more of a functional issue, which might have more physiological goals that we need to chase. So your typical patient for that might be someone who's just ruptured their Achilles tendon and has come out of the booth and actually has a significant atrophy to the calf. Someone post ACL, not that I see them anymore, but shoulder dislocations, and I know that with an ACL, the quad strength that someone has is quite closely correlated with their outcomes and explains quite a lot of the variability in outcomes. And so if someone's not getting that back, then I need to have quite specific regime in place, and I need to test, and I need to create a plan with more strength and conditioning principles as to how to help that patient get there. If I'm seeing someone who's got what I would classify as like a primary pain presentation, so that would be someone who's got maybe self-hammer pain, plantar pain, greater trapentire pain syndrome, which are conditions I suppose to explain affecting kneecap pain, heel pain, outside of the hip pain, that came on without trauma or an injury, then that's completely different. I'm not chasing tangible outcomes as much with this patient cohort. And so if I'm not doing that, I can't rely on strength conditioning principles to kind of guide me, then what do I use for that?
Sorry to interrupt you, because I think this is probably a really interesting point. And is that because from your reading of the literature, strength doesn't correlate as well with resolution of that particular group of conditions? Because you see this quite a lot on various social media and stuff like that, well, if you've got this problem with your hip, all you have to do is get incredibly strong in your hip and it will solve your problem. And I think when you've been around the block a few times working in pain clinics and with the population for a while, you realise that you can get a fantastic strength outcome and not necessarily get the resolution of the pain complaint that person's coming. Sorry to interrupt you, but I think that's probably a great point to raise, because I think there is that misconception. It's all just about strength and conditioning.
Yeah, definitely. And if strength was the cause of the fact that an athlete wouldn't get pain, and I think probably what we can do sometimes is get too focused on getting someone strong, and you ask someone how the rehab's going, I'm going stronger, but my pain is just the same, or worse sometimes.
So common to hear that.
So however I kind of arrived at that conclusion is from reading the research, and off the top of my head there was a meta-analysis looking at does quad strength mediate outcomes in knee osteoarthritis? So mediate being, does it cause the outcome? And knee strength caused 2% of the outcome in exercise interventions with knee osteoarthritis. Again, there's different studies. So one by Merseyside, I think in 2021, looked at 3 arms. So one was high load exercise, it's quite a rigorous in-person strength conditioning program. Low load strength conditioning program, again in person or in attention control, where people didn't receive what was considered to be the active ingredients, but came in, had time with the therapist, had time with the group that they would have had, the social aspect in the strengthening groups, and there was no difference between the outcomes of the treatment arms, and so you can conclude from that it wasn't the type of strength training that was given that was mediated the outcomes or caused outcomes. It's something else. We don't know exactly what else. And strangely enough, I can never get my head around this, but I'm pretty sure the strength outcomes weren't that different either.
Oh, really?
Yeah.
That's very worrying. Okay. Yeah, so I suppose that alludes a little bit to sort of vague therapeutic alliance, therapeutic effects, and this is why I suppose I was a bit surprised to hear you mention manual therapy, because that's a tripwire right there.
Yeah.
So are you happy to talk a little bit about your opinions on manual therapy?
Yeah,
is that something you're able to use in the NHS at the moment, or?
Yeah, absolutely. It comes down to the therapist reasoning, and I think definitely I've noticed a shift over the past 5 years that I think it's being used less in the NHS and the public sector. And I think people go through phases then, because everyone's chasing specific effects of treatment. You want to know what the active ingredient is and be able to apply that to everyone to help them get better. And it's been quite famously put out there on social media and circles within physiotherapy that manual therapy doesn't have the specific effect that it was once kind of proposed to. And so I think the message has been a bit misinterpreted by myself at some points as well, as well, if we don't know the specific effects, then it doesn't have any clinical value. But that's wrong. I think that it's, we know that people do get effects from it because they tell you after you've done it, and people can say, this had great effect with me. So it's more, I think again, it comes back more to how you deliver the message and how you deliver the rehab. If it's just used as a tool to try and help get someone better, just like exercise and the be all and end all manual therapy isn't either. But it's used selectively, it can help. I'll probably just add to that I don't do a lot of manual therapy. My opinions about it have changed quite a lot. So I think going back to when I first started, there was a lot of conversation about motion palpation and can you palpate a stiff joint and different grades working to stiffness, which kind of put me off quite a lot because it didn't really compute. And so I was kind of against it for a while, but the more I've learned about, because I went from the manual therapy camp to the exercise camp, but now I've realised that exercise is going through the same thing as manual therapy did then, and a bit more balance and manuals.
Yeah, so, and I suppose there's also all these different, what puts people off is these different sort of approaches to manual therapy that can be very sort of complicated, and all these kind of hoops that you sort of have to jump through to gain these various competencies. My approach to manual therapy is quite strongly based in sort of what I learned from a mentor of mine called Thomas Mitchell, who's UK, and we were talking about him, weren't we, off camera as well, UK Mulligan lead, and you know, modifying symptoms within session and taking patients on these sort of, if you like, journeys of showing them how they could move and modify their pain, even temporarily, can be very powerful for someone who's been in sort of constant pain for a long time, and then you show them actually you can use a particular movement, you know, to modify your pain, even if that's just temporarily, and that can be a gateway then to exercise and some more positive sort of outlook on result, perhaps.
Yeah, it comes down to the narrative, doesn't it? The narrative that you give alongside it. Because my views probably would be that you don't need to be too specific with it. There's many things that you can do.
I'd agree.
You know, there's not one technique. And the message that I would give after it is, look, it's been 10 minutes and we've changed your symptoms. To me, that's really encouraging that it has the ability to change.
Yeah.
I don't promise that it will change.
Yeah.
I don't promise that, you know, I will continue to do this for an extended period of time. It's just more to demonstrate that, because you're absolutely right, to certain patients that is needed, isn't it? They need evidence that there is something that could be done, even if it's only temporary.
Yeah.
So yeah.
And I don't really see it that different to, you know, take for example an exercise like if you said to me you can only have one exercise for the rest of your life to keep healthy, resistant, I'd probably choose a squat.
Yeah.
You know, so if I've got someone who is completely wrapped up in their ability to squat and their training and doing, and their knee starts to hurt when they squat, and I tell them, well, okay, let's change the foot position slightly, and it takes the knee pain away when they squat.
Yeah.
It's a form of symptom modification, you know, in the same way as putting my hands on their knee and changing the position of the knee while they squat takes away their pain. But then you're trying to transition that into some sort of independent self-management.
Yeah.
Rather than saying, right, for the rest of your life you've got to come and have me manipulate your knee while you squat. You know, that's not really what it's about, is it?
If anyone tries to fairly fix something with the hand, so that's an immediate red flag, isn't it?
Yeah. So okay, that's cool. So we're kind of getting into this now a little bit then on the rehab side. So you've alluded to this sort of area of exercise kind of going through its manual therapy crisis of we're struggling sometimes to find evidence of effect for particular exercise programs. And I suppose people would push back and say, well, a lot of these exercise programs or exercise approaches that are published in the literature often aren't that great, or they don't necessarily reflect what I would do this better. But it's, you know, I think it's true to say that, you know, the effect of exercise is known to be beneficial on a wider, broader health spectrum. But when it comes to managing particular pain complaints, you know, lower back pain, knee osteoarthritis, it starts to get a little bit more hazy. Yeah. And you're well known, I think, on your Instagram for sort of talking about things that are a bit wider than exercise. I've written down ecological dynamics.
Yeah.
Do we dare go into that? Shall we have a go?
Yeah, absolutely. So ecological dynamics is essentially like a scientific way to observe human movement. It's a branch of research, and a lot of people who are interested in skill acquisition will look into it. So how do you coach someone to be a better football player or a better basketball player? How can you change someone's shot with basketball? I'm a previous basketball player myself. I don't know anything about football.
You've got the height for it, haven't
so
you?
I've got the height, yeah. I don't have much else for it, I'm not skillful. But yeah, I'm rubbish for football, so a lot of my analogies won't be football related. But yeah, so that's how I first became aware of it, really, of interest in that area as well, just from a kind of understanding point of view. But then kind of think, well, how can we take these ideas of how you can visualize movements and bring them forward to rehab? Because it was quite a moment for me that I'm a physiotherapist, and within physiotherapy we regard ourselves as movement specialists. But I didn't actually understand why someone moved in the way they did, or much about it really. So that kind of curiosity is what kind of fed the appetite to look into this. So ecological dynamics, in essence, is a combination of two different theories that look at movement science. So one is called dynamic systems theory. So that was kind of coined by someone called Colin Yule back in the 80s about kind of pediatrics and children, how they learn to move and how they develop the motor patterns that they've got. And it essentially boils down to the proposition that movement arises from an interaction of different, what he called constraints, different variables. So one would be a kind of the task variables. So if we take the example of someone on a basketball court.
No, not basketball.
No, not basketball. Okay. No,
Badminton court.
Badminton court. The goal, the task goal is to, it changes from moment to moment. So it could be to reposition yourself in anticipation of receiving a shot from the player, or it could be to position yourself to smash something. The task at that point in time dictates how you're going to move.
Okay.
The environment will also dictate it. So that isn't just the physical environment. So if you have someone who's walking outside, their movement patterns will be dictated depending on whether they're walking up a mountain or they're walking across the street. If the environment is quite hectic, you're dealing with opposition players. They're in the environment, they're going to dictate your movement options. They're going to constrain what you can do in that moment. And then we've got individual constraints. So, in a rehab setting, that is, does someone have enough quads strength to decelerate them in order to change direction at the angle that they need to?
Yeah.
Does someone have the rate forces on their calf to actually jump up and reach the basketball,
the shuttlecock.
The shuttlecock, yeah. Do they have pain, which can limit their movement options? Do they have the range of movement? People quite commonly will see in our departments of post-fractures, post-traumas. Sometimes you don't restore full movement. How does that affect their movement patterns? And so human movement is proposed to arise from an interaction of all these constraints. And it's a reciprocal relationship with the environment. So it's called kind of action perception, or it really should be called action cognition perception. What I receive from the environment will change how I act, and how I then act on the environment will then change how I perceive it. So it sounds quite complex and convoluted when I've described it like that maybe, but it's essentially a way to visualize what dictates how someone moves. And then the ecological side of it is it's more of a psychology side. So ecological psychology is a proposed way to view cognition, and it relies heavily on kind of perception. So how do we perceive our environment? And this has been around since like the 1970s, or even earlier. And it's filtered through into many things, like how do we design doors or a kettle? How do we perceive the objects in front of us? And through what is described as this kind of theory of affordances. I don't know if I'm going too off piece here.
No, that's fine, but you're going to have to explain what a theory of affordance is.
Yeah, so theory of affordances is, so I'll take it back a step. If we talk about perception, we don't tend to perceive our environment in terms of dimensions. I don't look at a window and think, oh, that might roughly be 1.5 meters in height. And I don't look at a chair and think about things. I perceive it in terms of what I can do with it, what that particular object affords me. If we take it back to badminton, if you have a look at a shuttlecock, its position, its velocity, you don't think about those things in the second. You instinctively perceive that as, I can return that or I can't.
Yeah.
And so your perception is what we call embodied. You don't think about it, you perceive it directly in terms of what it means to you.
Okay, yeah.
And so the theory of affordance is tied in with that quite a lot. So an affordance is an invitation to action from the environment at that point in time. So, thinking about a flight of stairs, if I'm fresh, I haven't been to the gym, I'm not done legs day, I'll look at the stairs and, I instinctively know I can leg it up those stairs.
Yeah, it's an opportunity.
It's an opportunity.
Yeah.
If I've just done leg day and I come back, that's not something that I'm,
it's a threat.
It's a threat, yeah. I'm not going to be able to do that.
Yeah.
If and so it's that kind of, what does the environment, what's it inviting me to do? If you're on a football field and you're making, a breakaway to the goal, you've got a couple of defenders in front of you, then you don't think about they're this far apart, so I can maybe thread through and get around that way, or I could next this person because their legs are, you perceive it in terms of what it's telling you. It's not, there's no kind of active cognition in it. And so based off what you perceive, you might then decide to either try and get through them or go around them. And again, that perception will affect your movement choices. So ecological dynamics is just a framework to try and understand how someone moves, or why they move in the way they do.
So and that's really interesting. So, and what do you take from that as a so that's all interesting from a movement science point of view and a sort of an explanation of movement. But how are you then? You strike me as someone that likes frameworks.
Yeah.
Yeah. So how are you using that framework to influence your practice?
So I'm a big believer of beginning with the end in mind. So again, in my head, how it works, if I've got someone who's had a structural injury, they've got physiological problems, it might be someone who wants to get back to badminton, having had a Achilles tendon rupture. I know what their end goal is, and I can visualise from like a needs analysis of what that might entail. So they're going to need to get peak strength back, they're going to need to have good rate force development, they're going to need to have full range of movement and everything else, up the chain. They're going to need the confidence to do that. These are all things that I would term as individual constraints. So they're going to shape the movement. If someone doesn't have the capacity of their strength or movement to actually jump up and reach that shuttlecock that they previously would have been able to, that's going to constrain their movement options. And so I can't control the environment or the task that someone's returning to. I can have some control over the individual constraints. And so my job is to try and restore those and minimise how many constraints someone's returning back to sport with.
And also to provide evidence to that person that you've ticked off, because often people come back and maybe they're on a less structured rehab pathway than perhaps you're describing, but people often come back and say, I'm just not ready. I don't know why, but I know that I'm not ready. And then as the therapist, you're sort of digging down and figuring out, right, okay, not in a professional sporting environment. I think probably your approach there is being formalised really effectively. But for most average Joe, they're probably just making their own, some of them are making their own decisions without the help of a physio, making some of those calculations that you've just discussed there to say, yeah, I'm okay to play five-a-side on Wednesday, or no, I'm probably not. And then when they get it right, they get away with it, and when they don't get it right, they re-injure themselves straight away and back out for another 6 weeks. So I suppose proving, as a therapist, you're looking for evidence and then also trying to prove to them that yes, you have made that, because you don't want to keep people off from a health perspective longer than they need to be kept off. So these little sort of, right, okay, you're going to demonstrate this jump and this component of it. Did you think you could do that? Oh no, I didn't think I could do that, but now I realise I can. And then they all add up. and become a return to play.
Mm-hmm.
Okay, yeah, that's interesting. So how did you come across this sort of system of thinking, or is it just something?
Yeah, it's to be honest, I first there's a physiotherapist called Eric Mira.
Okay, yeah, his podcast. I remember him. Yeah, Eric Mira podcast.
So he does
a
PT Inquest, which I loved. I listened to all the episodes, and he does some online courses, and he's very much like a critical thinker. It's quite inspiring to listen to him and think why you arrive at that conclusion, because he can clearly say why.
Mm-hmm.
But part of his thing was like, why do we move? And so that introduced me to dynamic systems theory, this kind of idea of interacting constraints, and his idea of what a clinical application would be for that. And then from there, I've kind of branched off. So there's different resources. There's the Action Perception podcast, which is run by a guy called Rob White.
He's the Irish physio.
He's actually not physio. He's from America, US. He's a professor at university.
Yeah.
He's published a lot into kind of like baseball and movement patterns related to that. But the podcast is really good because it explores all these terms and ideas. And he's written a book called How We Learn to Move, which is a really easy read. Read it a few times. And so and then there's a few like-minded people in the sphere. It's one of the great things of being online is you can find people who are interested in what you are. And so having discussions, seeing what they're posting, kind of come up with that idea. But again, it comes down to, like, for me, it quite nicely fits a framework, and I think if we're finding that the outcomes aren't based on what we thought they were previously, we need to have a common language of how we arrive and how we plan our rehab. And ecological dynamics, it does that for me. It can sound a bit weird at the start, but it does.
Yeah, it's got some long, complicated sounding words in it, but actually I think I wasn't aware of that, all that terminology. But I think if you've worked with people and kind of worked on the cold face of rehabilitation, you come to these conclusions gradually through experience of, right, just by addressing impairments doesn't necessarily result in an action. And actually I think one of the big things is if you're a physiotherapist working in a clinic room and you don't get out and see movement in real life. I've had the benefit of having been a qualified badminton coach.
Right.
So you might do some treatment with someone, do some strengthening, and then go and see the result of your work on the court. And you think, I've done all this impairment-based, work, and it's just not carrying over.
Yeah.
So I think I've sort of come to similar conclusions through that experience without realising there was a proper theory to back it all up.
Yeah, I suppose that's kind of why I like it. It's because what I've just said is groundbreaking. Like, obviously, if someone's got a weaker leg, we need to try and strengthen it back to normal levels.
Yeah.
So it's not groundbreaking in that sense, but I think it does offer a common language for us to talk about these things, because everyone's got our different languages and different thought process and how we arrive there, and kind of unifying that is how we're going to push forwards, I think. And if we've addressed all the individual constraints, but someone's just still not there, then it guides us into what else we can do, and maybe we need to look more at their perception and their affordances, their field of affordances. So one was like a little thought experiment of like, how could I apply that clinically, or what would I like to see? I actually wrote a blog on it, but it's this idea of, with our ACL patients that we see, we're very much impairment based, which we need to be, because people have big quad deficits in particular, alongside other things. And we're, within RUFs, like the Liverpool Hospital, we're really good at doing that because we've got a nice connected dynamometer, we've got access to force plates, like we can track and measure it. However, there's still people who will report quite low knee function and low psychological readiness. And so the answer to those people who've restored everything, we've reduced their individual constraints, like they're not constrained by their physiology, but they're still reporting these things. Inevitably sometimes we're not going to be able to do that because the knowledge of I could re-injure or my partner's telling me that I can't go back to football because it can't put up with me from the year of rehab or whatever. We're not going to be able to change that, but there's probably a lot of people that we can try and change, and so I would really love to see, can we try and get more ecologically rich rehab?
So what would that look like? So you addressed, ideally, the way I would see it is you'd be doing these things concurrently. So rather than address all the impairments and then hope that that works, and then when that doesn't work, go to this ecologically rich environment, you should be kind of building this rehab plan with somebody trying to identify whether it's psychological profiling, and in reality most physios don't do psychological profiling, but you're picking up on cues of fear avoidance and things like that, and trying to, let's take an ankle sprain, you might be addressing eversion strength, hip stability, proprioception, and at the same time maybe you get them doing a small constrained drill, a two-step, a dance move, something that's a bit fun, that builds that confidence and fluidity of movement at the same time, and that becomes gradually more complicated. So I've probably stolen the question just by getting excited and banging on about it. But is that how you would see it, or is there anything you would build onto that?
I mean, I agree with you exactly. You shouldn't wait for one to be done to then work on the other one, ideally. I mean, there are some people that you rehab really well and have no issues getting back, so actually just addressing the constraints is enough for that portion of people. And so part of the problem is identifying who do you need to do this for, but I would argue that we should be doing it for everyone, so we're not missing anyone. So the kind of idea that I came up with, which would be in practicality really hard to implement in the NHS, is this idea of kind of like rehab games almost. So someone who's had an ankle sprain, if it's a high grade and we need to be protected with tissues for a certain amount of time, similar with after ACL we need to be protected with the graft for a while. That's where the knowledge of biomechanics can come into it. So just because I know a little bit more about it, if we talk about ACLs, with the risk of re-rupture, we know that the main ingredients for an ACL rupture is actually the joint reaction force, the joint compressive forces. You get that from having large ground reaction forces. So if you hit the ground hard, it hits back at you. There's much more force that the knee has to deal with, and so it requires less movement error in quotation marks that actually damage the ACL. So and that's why we typically say you shouldn't return to sport until at least 9 months after a hamstring graft, because the graft probably isn't strong enough to deal with those forces until that time point. And that's why we advise people don't go back to being involved in these environments where they might have to push off really quick and slow down. But actually, if we know that the ground reaction force has really close correlations with how much force the joint has to deal with. So can we constrain the situation, implement environmental constraints and task constraints that will reduce the magnitude of forces we have to deal with. So everyone's into footy, aren't they? So could we get a sport hall, instead of having a full-size sport hall, have half?
Constrain the size, reduce the increase the space for deceleration zones, reduce it for acceleration. Those sorts of things.
Exactly, and have someone there who's refereeing, and if anyone breaks out into a run, it's a foul. It's too much force. You need to walk in football. Can you have the goals smaller than usual, so it doesn't encourage shots from a distance? So you're kind of constraining the environment and the task to allow people to embed themselves in the situation where they've got to analyse if we're speaking formally, their field of affordances, and they've got to try and figure out, how does my new knee or my new ankle, because it's different to pre-injury, how do I feel moving around with that? And it's embedding them in that environment to explore that from day one. And actually, if someone's doing that from, not day one, maybe at a reasonable time point, if someone's embedded and already doing this sort of stuff, then suddenly the return to that doesn't seem as off-putting. And maybe there's a correlation maybe there would be a correlation between that and psychological readiness. That's kind of a theory that I'd love to explore, but it's just...
It's making me think of the England cricket team, because one of their things they're sort of famous for is they play a constrained form of five-a-side football
Right.
to warm up.
Yeah.
And I think they kind of got criticised for it because once someone stood on a ball and like twisted their ankle before a crucial game.
Right.
But in general, I've always thought it's a really safe way to warm up because they're in a really constrained zone. They can't get enough speed up to kind of have any high impact tackles. They're having a lot of fun. It's very chaotic. You know, lots of movement variability. I always thought that's a great way to warm up. And it's basically one of these constrained. We use it a lot in coaching. You constrain the variables of the court to try and develop a particular skill set. But you can only use this part of the court, so you become really good at playing a particular type of shot that you can only play in that part of the court. So it makes a lot of sense to me, but I suppose it's probably something that could be pushed out more widely as a rehab skill set.
Yeah, I think so. I mean, it's something that I've thought a lot about. So people who've never heard of it before, I'm thinking it sounds a bit convoluted. But again, I come back to it's a common language. Actually, and we can. I immediately know what you're on about because I understand the language with that. But you just touched on kind of movement variability. I suppose that's something I haven't mentioned yet, but that is essentially one of the big rehab goals for us. Gone are the days where we thought that there was the right way to move. Actually, we're increasingly realising that probably what we want is a huge amount of wiggle room. You know, bringing it to a re-injury perspective of someone who's had an ankle sprain or an ACL or whatever it is. If we don't provide them with the movement options to get out of sticky situations, then they're much more likely to re-injure. And so because one of the key fundamental aspects of ecological dynamics is that an organism, as they term it, but essentially a human or any living being, will self-organise. They will arrange their movement patterns in line with the constraints in their perception of the environment. So, you know, they will move in the way that it dictates. They will self-organise that movement, and we need to be able to allow people to self-organise in any number of ways to get them out of situation A, B, C, D.
And also to strip it back to biology again, if you take that ankle injury again and you only rehab them in a particular plane of movement, you might regain that deficit in dorsiflexion, ability to flex your ankle, but the capsule of the ligament is 360 degrees, and if you're only stressing that one, you're going to get that adaptation in the passive structures only in that particular narrow field, and it doesn't represent real life stresses and strains, does it? So that variability for confidence, but also for tissue viability and tissue health is crucial, isn't it?
And it comes back to testing, as you said before. You know, testing inversion in someone who's got particularly a chronic ankle disability is really important. And it's again, you measure it to address, how I would phrase it is, you measure it to assess where we are with the individual constraints. Is this still a big constraint, or have we resolved it? And we should focus on something else.
Okay, so I'm a bit conscious of your time as well, so you've been really generous with it so far. What are we on? We're doing quite well actually. So I wanted to talk about a final subject which I think is quite dear to your heart, and that is the importance of mentorship in clinical practice. So why is mentorship so important, and what are you doing about it?
I think mentorship is kind of crucial. To me, mentorship is having a figure that kind of pushes you and questions why behind things, which is kind of a crucial question we should all be asking ourselves. And it can take different forms. So, you know, throughout my work career, I've had different mentors. They've probably all known that they're my mentors, but I've been kind of, you know, what they've been asking me, what they've been prompting me to do is push me forwards. That's obviously not an official kind of relationship as such, apart from the contractual obligation to make sure I'm not doing things wrong. But it's a kind of a realization that we all have supervision structures in work, and especially in the NHS, they're very clinically driven. You know, talking through patients that might be struggling with, in terms of creating a plan or where do we go next. But it's rare that you find the time that you can sit down and run through how are you developing, what do I need to work on from my clinical reasoning, from my knowledge of things, like how do I get to where I want to be. Again, it's, what's the end goal for you? Beginning with the end in mind. If someone might have a very clear idea of where they want to get to, and having a structured plan delivered by, or not delivered by, but kind of facilitated by a mentor can be really helpful. In terms of just reflective questioning, so what do you need to get to that point? Helping you maybe consider different routes of questioning, of like, what do I need to actually do to achieve my goal? I did quite a lot of it through the CSP, which is like a free online mentorship program.
And the CSP is the Chartered Society of Physiotherapy, just for those that not physio speakers.
They have an online process where you can sign up to be mentored or to be a mentor yourself, so mentee or mentor. So I was a mentor to quite a few people, and generally speaking it was people who tended to be fresh out of university. They saw my profile that I'm musculoskeletal, I've got interest in X, Y and Z, and kind of booked on to have a chat with me. And do my best to meet them where they're at, and it's not, at the end of the day, a supervision session or a mentorship session isn't my opportunity to demonstrate what I know and what I think is important. It's to listen and reflect back. And I realised that people were probably engaging in that mentorship process more out of a maybe lack of clinical supervision in work, and it wasn't quite hitting the spot as I thought it. So I've recently started doing my own kind of mentorship, and with the acknowledgement that I'm not going to be the right mentor for everyone. There'll be people who would listen to my thoughts and completely disagree with me in every sense of the word. But the background I've got and the knowledge that I've got, it does set me to think in a certain way. And so I suppose having an online presence, people can have a look at that. Does it fit with them? And then for the right person, I can offer mentorship sessions for them. So it's something that's a slow builder, because not everyone.
And also mentorship is having sort of been on both ends of this, is having had really sort of generous NHS clinical mentors and practice mentors and stuff in the past who, like you say, probably don't realise that they were mentors. But and when you sort of look back at it, you think, wow, they gave me a lot of their time and invested a lot in you. And then being on the other side of that, then you suddenly think, well, actually, I'm a kind of an informal mentor to this person or this person now. And it's very satisfying. I think people don't realise the mentor is getting a lot out of it as well, aren't they? Obviously, it's nice to get paid for what you do, but you can't beat that feeling of I've actually really made a contribution to that person's career, particularly when they're maybe new into the profession or maybe thinking of leaving or struggling so you go, oh yeah, I remember that phase. Because we all kind of pass through these different phases of being a bit disgruntled with it, and then if you stick at it, you pass through and get to the next phase, and it gets good again, and then it gets frustrating. So helping people through that is very rewarding, isn't it?
100%. And you probably don't realise that the conversations you have can be interesting that way, but it's definitely, I find value from investing in people and trying to help in different ways. So there's a natural kind of progression for me.
There's a skill to mentorship as well. You see different styles of it, don't you? And I remember, again, probably someone who didn't realise he was a mentor to me, but he's a physio down in Musgrave Park called Simon Ingram. And he's been very involved in setting up the advanced practice or FCP pathways down in Somerset and all that kind of thing. And I remember at one point I got very into movement screening. Do you remember the functional movement system? He was like quite a bit longer in the tooth at that point, and I was like, this is going to save the world. And was reading and listening to loads of stuff about it, and I didn't buy the kit, but I made the kit, you know, and then I was like, right, we're going to have it. And he gave me that space to play around with it, didn't kind of ridicule me, but gave me a little bit of gentle nudge that, hey, come on, this might not be all that you think it is, but gave me that space to play around with it and then reach my own conclusions. And I learned a lot looking back at how he managed that, because he could have easily killed a really good year of like excitement on my part by just saying, no, don't put that away, it's ridiculous, that's not going to do what you think it's going to do. So that mentorship is a skill, I think.
Yeah, definitely. Allowing you to explore that is invaluable to you, isn't it? From a critical reasoning point of view. And making, I suppose, when you're working with someone day to day, hopefully making someone feel like their opinion matters as well. Yeah,
that's exactly what he did. He's like, oh, that's really interesting, but just be careful of this, and you know. Brilliant. Okay, so mentorship then, if people are interested, which I'm sure they will be having listened to you speak there, where do they find you best? Is it your Instagram? Is there a website? Or?
Yeah, I've got an Instagram page, so it's at Morton Physio. The link to my website is on my bio. And there is a mentorship page there if people were interested. But I'd encourage anyone, if you were thinking about it, just message me first. Make sure it's right for you. I'm not in it for money, really, even though there is a cost associated with it for a time, but it's more about making sure I'm sure I'd be able to help you in some way. That's the main thing. So that's where to find me.
Superb. Well, Jeff, really generous with your time. Thanks for coming in, and it's been a really nice place to have a conversation.
Thank you. I would never have seen this room, not important enough.
I'm not really sure how we've ended up here, but we have. All right, mate. Is there anything final you want to say, or are we done?
No, that's great. Thank you very much.
Lovely. Cheers, then.
Thank you.